Good morning, good afternoon, and believe it or not, in some cases, good evening. We have people joining us from all over the world, and we are so excited at the response. My name is Carlos Velasquez, and it's a pleasure being with you. And I'm actually in Washington, D.C., and I'm with HMA Associates, and we are so honored to be supporting this effort. I want to welcome everybody and give everyone the bienvenida for our kickoff webinar for this 5-part series, Getting to Zero. Are we there yet? I'll be your moderator for today's session. Now, we do have some housekeeping items that we want to discuss. This session is being recorded. So if for some reason you don't want to have your image recorded, just leave it as is. And if you don't want your name to show up in the recording, you can use any name you want. Last week for the other session, we had Mickey Mouse, and he loved the session, but didn't want the world to know that he was part of the session. Please keep your audio on mute when you're not speaking, and we'll let you know when we actually have an opportunity for Q&A. And we've allowed for at least 2 breaks during the session to make sure that their questions can be addressed. Now, if you have any technical issues at all, you can send a private chat to Adam Ungson from our company. At all, anything you need, we're here to help you out. We're also asking that if you want to get, and we're asking that you do this, that want to get the evaluation link, go ahead and send your name and your email to Lucas Collazo, also from HMA, and we'll make sure you get the evaluation link, but we'll be posting it in the chat box, so you'll get a reminder one way or another. But the other thing too is if you want to get a recording of this session, this is how you get it. I mean, send your email and you definitely will get it. I do have one additional statement that I need to read because we have to comply with certain privacy laws, and that is that by attending this webinar event, you are agreeing to the policies of the county, and you will not hold us, either liable or sue us, we'll put it that way, for any claims, demands, rights, or promises. This is just protecting us, it's protecting you, and so we're saying that you agree to this, then thank you for being here. Now, it's my pleasure of introducing Dr. Sarah Lewis Rudman. Dr. Rudman is the STD and HIV controller and assistant public health officer for the County of Santa Clara. She trained in internal medicine at Brigham and Women's Hospital and adult infectious diseases at UCSF before completing her MPH at UC Berkeley. She worked at the California Department of Public Health in infectious disease, outbreak investigation, and bioterrorism pathogen response prior to joining the County of Santa Clara Public Health Department, where she leads the STD HIV prevention and control program and serves as medical director of the county's STD clinic. Now, I am hoping, Dr. Rudman, that we can make these slides work as best as we can. Otherwise, just tell me to move them and I will do whatever you want.
Sounds good. So should I take over control of the slides?
Let's see if it works. We're having some issues.
Okay. So just requested control. Did that work? Excellent. All right. So I'll pause here and go over learning objectives. Thank you so much for the opportunity to help participate in this important webinar, and for everyone who's joining. We are thrilled at the participation. Thank you for that introduction. As some of you saw, I was married somewhat recently, and so my name's changed from Lewis to Rudman, but you may find me under either, anywhere you look. So a couple of things we're going to talk about, and again, the data we discuss and the particular experience I describe is going to be specific to Santa Clara County, California. For those of us everywhere else who are joined, we're so grateful to have you, and we'll be really interested to hear how this experience compares to yours. You may find that there are parallels or things that are dramatically different. And so I'll be very, very excited to talk about that. If you don't know us, we're here in the southern part of the San Francisco Bay Area in California, and include San Jose, California, which is one of the largest cities in the country. So we'll talk first a little bit about COVID-19 response and how some of the parallels to the pandemic response really match the lessons we have been learning in the HIV and STD world for decades, and where that COVID response lines and doesn't align with where we are in the HIV world. We'll talk about the local HIV and STD epidemiology here in Santa Clara County, some of the best practices in STD and HIV prevention, and again, thinking about how we standardize that, how we make use of the tools that we have in the STD and HIV world that we're all very aware we don't have in the COVID world right now. And we'll talk about clinical and public health opportunities to address social determinants of health, which we'll talk about how that's been for a long time incredibly important and sort of the crux of HIV and STD response, and is also really the crux of the COVID response as well. So let's see if my slide advancing works. Oh. All right, I can't tell if I have control to restart this. Let's give it a try. Okay, there we go. Excellent. So here in Santa Clara County, we are, I think, an amazing place to live because we are an incredibly diverse community with a lot of travel. And it was that international travel that was probably the reason why we were one of the earliest hit locations in the entire country. We had one of the very first cases. I think we were case number 6 in the entire country, as well as case number 12. And of the first several folks even considered for testing, we had a majority of them. And so after our very first case, which was at the end of January, we were aware that we were already having community transmission by the end of February. And if you look here at our epidemiology curve, what you see is an initial peak, surge that happened in cases as that initial community transmission really overtook us, and we were able to identify it by the testing we did have at the time. That peaked around 70, 80 cases a day in April. We were also one of the very first counties to recognize that we did not have the case-by-case response capability that would allow us to contain this local transmission without massive undertaking of what we call movement restriction and social distancing. So in addition to having early on made recommendations around people reducing interactions with others as much as possible, we were one of the first places in the country and the first in California to issue a shelter-in-place order, a mass order requiring every single person who could to remain home. This closed schools, this closed all non-essential businesses, and this happened for us around March 19th. And I think was the reason we were able to see that initial curve drop off. We did see sort of a second bit of a peak just after that in early April, which was unfortunately driven by outbreaks in skilled nursing facilities, which we knew was sort of this perfect tinderbox for transmission and unfortunately illness and death because of both the medical fragility of the members who live and sometimes work in skilled nursing facilities and the congregate setting and the way that disease can pass quickly in those settings. So we did see that sort of mini second bump in April due to that. But then we experienced quite a lull through May, at which point we recognized that the ongoing economic harms of the shelter-in-place order had potential to cause not as much harm as COVID itself, but some harms that we needed to try to mitigate as well. And so as soon as it seemed safe to do so, we began to open up additional sectors of the economy, things like construction and other outdoor businesses that had reduced apparent risk for transmission. And we then did unfortunately start to see cases rise and transmission rise in that setting. And so had to, again, further restrict some of those openings in July. And actually at that time decided to restructure our shelter-in-place order using what's called harm reduction principles. And for those of you in the STD and HIV world, the idea of harm reduction principles is something you've been thinking about for a long time. It's also sometimes referred to as meeting our clients where they're at. And this is the idea that different responses, different risk reduction needs are gonna be appropriate for different people. For some people, you can say, stay home, don't leave the house, don't interact with everyone, and that is doable. For some people, that is not doable. They're gonna make a logical, rational decision not to follow that instruction because they provide an essential service to the community, because they care for a family member who would not survive without it, because they care for a child who would not survive without their interaction, because if they lose their job or lose their home, they won't be able to eat, they won't be able to survive. And so people are making rational decisions around what types of risk reduction recommendations they can follow and they can't. And it was necessary for those reductions to address each of those circumstances. And we'll circle back to why we've been thinking about that in the HIV world for a long time later on in the talk. And so what I want to point out from you as we transition here to the other thing I think you should know about Santa Clara County, we also, oh, I'm so sorry. Let's try that again. We also had some of the very earliest deaths. We were aware of our first death in late February, but a retrospective analysis actually showed us that we had had a death as far back as February. And this was somebody who had not traveled, but may have come in contact with folks who had traveled. All right, let's see if we can get this going again. Okay, so we'll stay here and just move forward from this slide. But what that death curve showed you a moment ago was that we had an initial surge in deaths in March around the time that we were seeing that first surge in cases, and then another surge in deaths around July and August when we were seeing that second surge in cases. But again, we found out even before then that there were very early deaths in Santa Clara County. Back when we had very limited access to testing, we knew that we had to try to learn as much as we could about the pandemic, about how the epidemic was affecting us locally with every other tool that we had. And so our medical examiner at that point was keeping track of every death that looked like it could be associated with COVID, but we didn't have the ability to test at that time, and retroactively went back and tested those cases later on when we had expanded testing access. And identified that February 6th and February 17th deaths were in fact COVID deaths, even though we didn't know it at the time. And so we did in fact have community transmission, even though we didn't know it. And once again, that idea that there's transmission we don't know about, that there's a population being affected by a disease and we don't know who they are and need to think about how to find them, that's also a theme we talk about in STD and HIV all the time. And a key piece of what many of you are probably doing is trying to understand who's out there and undiagnosed. How do we find them? How do we target outreach to those folks in a way that makes sense, that doesn't reduce people to their risk factors, but also understands the reality of people's risk and how to offer them the tests they need in that context. So this next slide I have in front of you focuses on what I think is one of the most important things I've learned from our COVID outbreak. And this is that while very early on, our first case, our second case, and maybe our third had some association with the international outbreaks. They either had traveled to China or lived in a house with somebody who had traveled to China or Iran or somewhere else that we're seeing an international outbreak. It was initially about who traveled, who knew who specifically, but almost immediately, once we started to see community transmission, the outbreak transitioned to being about social determinants of health. It transitioned almost instantaneously to be about who had the best access to healthcare, to testing, who had the ability to decide whether they went to work tomorrow or not, or who was going to lose that job and not be able to pay for food for the next month, or not be able to pay their rent and potentially lose their home. We saw a transition to the same communities who have been harder hit by almost every other disease category, including HIV and other STDs, almost immediately. We saw it affect populations of color, especially in our community where we have a very large Latinx community, and where especially those folks are impacted by dense housing, by poverty, and by work and service professions. We saw our Latinx and also our African American community members disproportionately hit here almost right away. It stopped being about who had a relationship with somebody who had traveled to China, had traveled to Iran, had traveled to Italy, and it was about where you lived here in Santa Clara County and what resources you had at hand. And we saw this affect our case rates almost immediately, and we saw this affect our death rates almost immediately. And you see that borne out on this slide, that in addition to things like age affecting vulnerability for death, We saw gender affecting it because it had to do with who was still leaving the home. We found early on, and this is actually no longer the case, that women were more likely to be able to stay home at first, while males were more likely to leave to do things like delivery jobs or other service professions. But as you see on the right side, our deaths were dramatically initially Latinx and also Asian, but not necessarily Asian communities connected with places like China where there was early transmission, but often our Vietnamese community that was more impacted by poverty and documentation status and service work and dense housing. All right, apologies for the slide trouble. Carlos, I may ask to see if you or your team want to manage the slides. We'll keep giving this a trial for a little bit longer. So again, this slide just shows further that argument that that early transmission very quickly shifted to being those who were vulnerable. What you're seeing in a map of our county is that folks in that dark blue area were hardest hit. First in East San Jose, that upper dark blue area, where again, most of our Vietnamese and Latinx community members live. And then in the southern area, which is a more agricultural region, also has higher rates of undocumented folks, of migratory workers, and again, of poverty and decreased access to healthcare and testing. We found more transmission. And for all of the reasons that we think we were seeing it in East San Jose, and all of the reasons that we see related issues in HIV and STD. We also saw very quickly and continue to see that it's not just the COVID risk of the pandemic that is killing people or disabling them, but the effects that the pandemic had on every other sector of the economy and on healthcare in general. A major concern for people with HIV or almost any other condition was that people would not be able to access other healthcare because the healthcare system was occupied caring for people affected by COVID, or because there were concerns that going to seek healthcare was not a safe thing to do. And so we were aware early on, locally and nationally, as you see from this article, that people were either potentially dying for not seeking healthcare. And we saw that locally here, an increase in things like heart attacks at home, where people didn't go get healthcare early enough to be saved. And we were worried that we're seeing that in the HIV realm as well, with people not keeping up with their access to care and keeping up with their medications and their viral load checks. Because they were either unable to seek healthcare, unable to get transportation to their healthcare visits, unable to do televisits because they didn't have, unable to have telehealth and internet access to be able to do that remotely. And we saw probably similar effects on our STD world, where people were not getting tested and therefore potentially being infectious longer and at higher risk for all of the complications from the STDs we'll talk about in a bit. Next slide. Actually, oh yeah, great. So this also shows that in addition to those healthcare cooling effects where folks were probably not seeking the care they needed in the time they needed it, either because they couldn't or they were reasonably afraid to do so, the shelter-in-place order itself was having economic harms. And so we expect that we're entering or have entered what's going to be probably one of the most severe recessions or depressions we've seen since the Great Depression. The job loss has been considerable, as most of you know. We're seeing companies close that aren't going to be able to reopen because they've, the period during which they had to close services lost them so much income they aren't able to maintain, affording their rents or keeping their employees on board. And the medical outcomes related to this prolonged poverty and job loss is likely also to be extensive. Now, on the public health side, we make decisions like issuing a shelter-in-place order, understanding, although never to the depth that we want to, these types of theoretical and now very real harms. But it was also understood at the time that the harms, including the economic harms and the non-COVID harms of allowing people to get sick and die, was probably the same or greater than the economic harms that would happen of shutting down interactions between people and therefore decreasing death, but also having these economic sequelae. So for the next slide, please. What this article refers to that I thought was so important, and from here we'll pause and then transition to talking about HIV and STDs. As Atul Gawande, many of you know, is a longtime writer in New Yorker Magazine, a physician, and an advocate for healthcare systems change that would help us respond better to everything from HIV and STD to the COVID response. And so in this example, he talks about how we've had a deficit in testing from the beginning. Again, parallel to our STD and HIV world, where in that case, we have plenty of access to testing. There are no labs that say, we don't have the capacity to run another test, or no situations where we've said, we just don't have enough swabs to test you for gonorrhea right now. But we have had barriers in accessing testing and creating a unified system that allows people to get tested, and the right people with the right timing, followed by the right access to treatment and prevention. And what Atul Gawande calls for here is better communication and partnership across all of the sectors that people interact with when it comes to health. And that's everything from public health departments like my role, to healthcare provision settings like a doctor's office or a clinic or a hospital, to community-based organizations that are on the ground interacting with folks, understand their fears and concerns, understand what information is reaching them and what hits home and what really doesn't. And if we had coordination across those groups, as well as in this case, things like the supply chain and sharing best practices, so that as soon as one person figures out how to create a drive-through testing clinic, everybody has access to that protocol. If we had that centralized, smooth communication and collaboration across all of these types of organizations, we would have much more rapidly been able to solve the deficit in testing that really stymied our early COVID response, where we thought we were seeing that low peak, but probably it was a much bigger initial peak, a much bigger amount of initial transmission than we actually knew was happening. We might have even known that we had the early COVID transmission in our community that we now know dated back into late January, that we were already having considerable transmission in our community, and we just didn't know it because we didn't have the ability to test everyone that we needed to. And so a lot of our work right now in the public health world in COVID response is about not just reactionary testing, not just testing somebody when they walk in saying, I feel sick, I've heard enough, I'm worried enough to come ask you for a test because of the specific circumstance, but instead we're really shifting to screening. We're shifting to proactive COVID testing because we know that a huge amount of COVID cases are asymptomatic, and waiting for someone to feel sick is only going to help us touch the tip of the iceberg. We have to set up systems for folks who are at the front line, like healthcare workers and skilled nursing facility workers and grocery clerks, to be able to get tested on a regular basis, regardless of symptoms, even regardless of exposure, so that we stay ahead of infection and can stop transmission before it's happening. And that's exactly what we're going to be asking to do in the STD and HIV world, with those exact same principles of paying attention to the social determinants of health and understanding how that impacts our patients, and of thinking about that cross-sector collaboration that's going to be necessary for us to really reach people at every stage of where they are, and thinking about and understanding their own STD and HIV risk, and getting access to the testing and prevention and treatment they need for whatever stage they're at. The last comment I want to make about coronavirus before we move on to talking directly about STD and HIV is one of the tools that we don't have in the coronavirus world is what we call biomedical interventions. We do have one medication, remdesivir, that does probably work when someone's very sick to keep them from dying. And it helps if we give it to it early on, but it probably does not help when we give them to people who are not really very sick. And we don't really know if it does anything to reduce transmission. We also do not yet have a vaccine, although we're all frankly holding our breath until we have one and making sure we're ready across every front to disseminate that vaccine the second we have one that is safe and effective. But we do have equivalent prevention techniques in the STD and HIV world. So in coronavirus world, we are relying entirely, almost entirely, on what we call behavioral interventions. asking people to change what they do, to make really difficult decisions about stopping things that otherwise would be part of their lives, and do things that don't seem natural or not people's first instinct when we for decades and centuries have been social beings interacting with each other at close contact, not wearing masks, not thinking about separating ourselves or staying home or using technology in new ways to reduce person-to-person interaction. That's all we have to rely on with COVID prevention, is asking people to change the way they behave. Where in the STD and HIV world, we've been doing that for a long time as well. And many of you who work primarily in this sector know that there are powerful ways that behavior changes can work to reduce risk of HIV and STD. But we often hit a plateau with that, where some people say, I'm just not going to stop having sex. And so we need other additional tools to help people have healthy, happy sex lives, but be able to do that with the lowest possible risk of getting sick. So here we'll pause. I imagine there may be a lot of questions about COVID, and we'll try to stick to just 2 questions now, focused on the relationship between COVID and STDs and HIV, before we move on to talking about those diseases specifically. So Carlos, do you have any specific questions we want to pause and ask now?
I sure do, Dr. Rudman. The first question comes to us from Arizona, and the participant wants to know why the gender differences early on.
Very interesting question. I think, like all of these disparities, we don't know completely. Our most striking difference when it comes to gender was related to death. We definitely saw that males were dying faster than females. And I'll pause here to say it's also been an ongoing frustration that we don't always have all of the data we want. So for example, we get very poor, I would say, data about what fields are filled out to report someone's sex at birth, what their biologic sex is compared to what their gender identity is. So we have very little information, for example, on trans men and trans women and their experience with COVID right now, although that's something we're working to improve. But again, looking at the biological sex differences, we believe we saw more deaths among males than females. And if there's a correlation that most of those males were men, we thought that we were seeing potentially more transmission that was affecting men early on. This absolutely may be because early on we were really focusing on testing people who were symptomatic because we had such limited access to testing. So we may have been finding more men, even if there were just as many women who were cases, because they were more likely to be symptomatic and therefore more likely to be tested. They may have also been more likely to be tested for other reasons, like access to healthcare, job-related health insurance, or working in a sector where we were doing outreach to try to access testing. We also saw that depending on the sector of the economy, there were more transmission. So for example, construction was one of the earliest fields that we reopened after having closed it. Construction is mostly men working in construction jobs, and we often saw early construction-related clusters of disease transmission. Probably not because there's anything about construction that makes it riskier, probably because we opened that up sooner. And so salon workers were not back at work, and so we're not getting exposed at work, while construction workers were back at work and were getting exposed at work. And so the parallel here is we may have seen decreased transmission in salon settings early on and increased in construction, and the gender difference really played out there. Now we're seeing more equal test and case rates among men versus women and males versus females, but still seeing higher death rates among males, and that may be related to things like higher smoking rates, higher rates of lung disease, higher rates of other cardiovascular disease, and higher rates of diabetes and obesity. So from here, we'll go to our STD focused content, because I appreciate, I'm a little behind already, even though we've got a full 2 hours to chat. Carlos, can I ask you to pull the slides back up? We're not seeing the slide.
Sure, thank you.
Thanks. If you want to, while you're doing that, ask one more question. We can probably do that quickly.
Yes, the other question I had, are there any changes in terms of disparities as more people are being tested?
So great question. And again, we are seeing that evening out of males versus Unfortunately, not really. We're actually, I would say, the more testing we did, the more disparity we found, because we realized that the same risk factors early on that were making someone likely to get sick, that they lived in crowded housing, that they worked in service professions, that they may have been less able to shelter at home because they were less likely to work in a job where they could work from home, or more likely to work in a job that didn't offer sick leave, which may have been incentivizing people to go to work when they were exposed or ill or just in general. Yep. Sorry, we're still not seeing the slides, so I'll wait for you to get those posted. But as we increased our access, so those same factors that made people likely to get sick made them likely to have lower access to testing early on. When you had to go to a doctor, make the case that you were sick enough to need testing, and the doctor had to get approval from the health department and the CDC to get that test done. Once we were able to push outreach to communities being disproportionately impacted and get testing everywhere and not just in higher resource areas, we actually found more and more disparities affecting especially people of color and people in service professions.
I'm sorry, Dr. Rudman, I have one more question that seems very pertinent here.
Please.
When contact tracing for STDs, are those persons offering COVID-19 testing in addition to the usual syphilis, HIV, since the things you do get an STD would also expose you to the coronavirus?
That is a great point. And that's actually something I don't touch on too extensively here, but another thing we have done is to work to make sure our STD and HIV prevention work, all of it has flexed to incorporate COVID. That's meant everything from rethinking how we test people, often trying to mail them test kits at home or bring them in and do contactless testing where they're swabbed themselves and pee in a cup. And then we have returned to using some more oral testing for HIV because that can be self-collected. So we've made sure all of the testing has flexed to be as little COVID risk as possible. We've made sure that the preventive education also talks about COVID and sex and how almost every type of sex act you might be having also it's sort of impossible to social distance while having sex. And so making sure folks understand their COVID risk. And so to your specific question, is COVID testing incorporated? That's something we're still working on. Here in our county, I would say a lot of the care providers who are offering STD and HIV testing are also offering COVID testing. And certainly if there were somebody who's at risk for both, trying to offer both. We have not specifically ramped up COVID testing in our STD and HIV focused settings, partially because we are still trying to get all the COVID testing we can to sectors that are so lacking. But I think that's something we need to ramp up, that recognizing those overlapping risk factors means that everyone who's due for an STD and HIV test is probably due for a COVID test as well, means we do need better integration of those testing resources. So I see one more question I have to answer.
Okay, Dr. Rudman.
I got it because I see it in the chat box and it's so good. Is COVID sexually transmitted? So while we think that COVID is transmitted in respiratory fluid, so we do not think it is in vaginal fluid or semen or other bodily fluids. We do think that almost every sex act where people are in the same room has a risk for respiratory fluids getting exchanged. We frankly have no idea if a respiratory fluid touching vagina, touching penile mucosa, touching anal mucosa can make someone sick. We know that respiratory fluid, respiratory droplets getting inhaled or getting in someone's mouth or nose or eyes can absolutely spread the virus. And so almost any sex act, almost any position has a risk of somebody releasing respiratory droplets and then landing on somebody else's face. So while any sex act that would reduce the likelihood of that happening, whether that's wearing masks, wearing eye coverage, wearing face coverage, that's going to reduce the risk of COVID during sex, but probably not eliminate it all the way to zero. And so just like we'll talk about in STDs and HIV, also being tested, also reducing your risk of COVID transmission elsewhere, also stable partnerships or reducing concurrent partnerships, all the same things that will reduce STD risk will probably help to some extent to reduce COVID risk. So here we'll move on to talking about STDs. We'll actually fly through very rapidly what the STD epidemic looks like here in Santa Clara County, partially because there is so much unknown. So we'll go to the next slide. So these are the trends that we've been seeing for a long time now, probably since the early 2000s, rising rates of chlamydia. And you see reaching in sort of the 8,000 cases a year that we see now. Next slide. And we see that across both men and women. We also see that among transgender populations, but we have overall very low rates reported, probably related to a lot of missing data. So you don't see our transgender community represented here on this slide. And you do see a disparity where more women and people of female sex are diagnosed, often because of what the testing recommendations look like. Probably there's not significantly more chlamydia making females and women sick than males and men, but more diagnosis happening. Next slide. We see the same pattern with gonorrhea, these rates going up and up and up, and even more dramatically so, such that we've seen about a 5 times increase from 2010 to 2019. Next slide. Here's where we start to see the real disparity play out here, where probably men and males are being truly getting sick with chlamydia, with gonorrhea, more often than females and women, not just a testing difference, and that is probably because of transmission among men who have sex with men, whether that's gay men or bisexual men or other same gender loving men. And we see a similar trend with syphilis, rates just rising and rising over the years, about a 6-fold increase overall. And going to the next slide. Again, seeing that even more striking disparity affecting men, and probably because of the disproportionate impact on gay and bisexual men. And so we'll talk again, here's that reminder that social determinants of health are so hugely in play when it comes to STD transmission, that the homophobia and transphobia, access to care, access to testing that has for a long time impacted gay and bisexual communities is played out here in the transmission rates that we see. But I do also want to highlight when it comes to females and women that we have seen an even to some extent greater increase in syphilis. And that's really scary because folks who are able to become pregnant who do get syphilis are able to then transmit syphilis to fetuses. And that can be a potentially life-threatening if that fetus becomes an infant. There can be early infant death, there can be miscarriage, there can be fetal loss, and there can be lifelong disability to that infant if born with congenital syphilis. We'll go to the next slide here. And so here's where you see specifically that congenital syphilis risk has been rising in a really scary way here locally. We're seeing this across California, and we're seeing it across the United States, especially across the southern US as well, where every time there's an epidemic that's affecting females and anyone who can become pregnant, we see the risk of that syphilis transmission to the fetus and infants, and very high rates of congenital syphilis. Next slide, please. So again, talking about social determinants of health, in the COVID world, we've been very worried about our custody settings. Fortunately, here in Santa Clara County, we've seen relatively low levels of outbreaks or transmission in our county jails. But in California prisons, both the state prisons and federal prisons, we have seen massive outbreaks and massive loss of life. And in parallel in the STD world, we see very high risks of STDs among individuals who are incarcerated in our jail system. And we do not think that is primarily driven by transmission in jail, although we do know that happens as well. What we think instead is that the same risk factors that put someone at risk for ending up in jail, whether that's substance use, whether that's homelessness, whether that's being a person of color, all of those same risk factors and being, subject to the structural racism that is related to folks ending up in jail also increases risk for STD transmission, especially transmission that isn't caught early and averted with treatment, reducing the risk of transmission to sex partners. A final element that comes into play when we think about custody settings and STDs is that we do know populations and communities that are disproportionately impacted by inequitable incarceration, also see disruption of sexual networks, see partnerships change over more often, which you can imagine happens if your partner ends up in jail for a prolonged period. There may be more changes of sexual partners, of relationships in those disrupted communities by disproportionate incarceration, and that's probably playing out here. And the way that that's most scary, I think, Here we're looking at chlamydia disproportion, and the next slide shows the same for gonorrhea, where we see an even greater disproportionality, but the next one shows a really, really striking difference in syphilis among females when you look at incarcerated versus non-incarcerated. And so here's why we care about that. When it comes to congenital syphilis, we already talked about this, that it both can be transmitted sexually, but also transplacentally for someone who's pregnant. It's diagnosed with a blood test, and it is completely curable with antibiotics. Penicillin, one of our oldest antibiotics, can absolutely cure syphilis, often with a single shot. But we have to catch it, and we have to catch it by testing people, not just because they're symptomatic, but because they have risk factors or because they are currently pregnant. Now, most cases are going to be asymptomatic, and when it transmits to a fetus and to an infant, if that fetus survives, we can either see death in that infant early on, or these lifelong disabilities from blindness and deafness and bony abnormalities and other neurologic effects. But again, treatment early in pregnancy has a 98% chance of preventing that infant and fetus from having any kind of downstream effect. And then we have a second chance to treat an infant born with congenital syphilis and dramatically reduce the risk of any kind of lifetime effects. But we've got to be testing the right folks early on and treating them right away. Next slide, please. And when we talk about risk factors for syphilis, again, it is the exact same story we've been talking about, from COVID to HIV to other STDs. Incarceration, substance use, homelessness or unstable housing, mental illness, especially when people are not able to access really high quality treatment and reliable access to medications for mental illness that need medications, recent visits to emergency care or emergency psychiatric care, lack of prenatal care, which again is related to all of these, as well as poverty and documentation status, and then having any of these risk factors in your sexual partner, even if the pregnant patient doesn't have the risk factor themselves. Next slide, please. Now I want to talk about HIV, where once again, we see these same disparities borne out. And here I think it is most striking when we talk about our Black and African American community. We see about a, what is it now? About a 5-fold increase in the prevalence of HIV among African Americans compared to white residents, and about a double rate among Latinx residents compared to white residents when we look at HIV prevalence in people living in Santa Clara County, and an even more striking disproportionate impact on LGBTQ populations, specifically men who have sex with men. That the vast majority of our local HIV epidemic is related to disproportionality affecting gay and bisexual men. Next slide, please. We further see outcomes not only in the likelihood of getting infected and being infected, but in how you do with that infection, that specifically African Americans are the least likely to be retained in HIV care and to achieve viral load suppression. And next slide. We also, again, we talked about the disproportionality affecting males compared to females, but what I think is really striking here is the effect on transgender populations. That, and again, I apologize that our gender and sex data are so conflated, where you see male, female, and transgender, and understanding those are usually different categories of how we talk about sex and gender. But what we do understand that our transgender population is probably especially feminine trans folks, trans women, are really disproportionately impacted here. And we see that most among trans women of color. And then we also see that this is still a fairly young epidemic, that it is our 25 to 30-year-olds who are getting hardest hit. Next slide, please. And then finally, again, I just want to show that disproportionality affecting our Latinx population. And it's also partially because we have a larger Latinx population than African-American population here in Santa Clara County that you see this here, even though we know that per African-American or per Latinx community member, the risk of living with HIV is higher if you're African-American. Next slide, please. And then finally, late diagnosis, which really relates to the likelihood of dying with or from your HIV, also, again, really negatively impacts our African-American community. Next slide, please. So things that are moving in the right direction, we touched on this in the COVID world, are our options for how we treat STDs and HIV, how we test for them, how we prevent them, and how we treat and respond to them to avert the actual negative outcomes that result from them. So next slide, please. I think in general, like COVID, we now have a test. We'll go to the next slide. Oh, sorry. Thank you. This one, yes. Screening for chlamydia and gonorrhea. So unlike COVID, we have not unlimited, but relatively easy, open, free access to very, very good tests for chlamydia and gonorrhea. And like COVID, we primarily use PCR, or what's called NAT testing for chlamydia and gonorrhea. We don't want to be relying on culture, on growing these bacteria, because those are much less reliable tests than the swabs that are run looking for the genetic material, which are highly, highly sensitive and almost never miss an infection. And because that testing is widespread availability and incredibly cheap, incredibly accessible, paid for by all levels and types of insurance, and even can be self-collected, just like we're now finally doing with COVID tests, we have widespread recommendations for screening. And again, we do not want to wait for symptomatic infections or for people known to be exposed, because we've got the testing. We know that most people are asymptomatic. We know that we've got to test them on a regular basis and not wait for another specific reason to test. So for females, the recommendation is that every female under age 25 get tested at least annually, and more frequently if they have additional risk factors like symptoms or a known exposure, or other things we've talked about like the social determinants, sex work, homelessness, substance use, etc. For pregnant folks, we also recommend testing at the time they are known to be pregnant if they're under 25, and at least twice in pregnancy if they have other risk factors. For men who have sex with men, again, the recommendation, because of those higher risks, is at least annually. And men who have sex with men especially should be tested at all body sites where one can acquire chlamydia and gonorrhea. That's a genital test, which is usually peeing in a cup for anyone with a penis, and a swab for anyone who has a vagina, a rectal swab, and again, these can be self-collected swabs, and a throat swab. And these should be done at least annually for folks who are men who have sex with men, if they're at all sexually active, and more frequently if they have other risk factors. For other males who are not men who have sex with men, the recommendations for routine screening right now are only in high prevalence settings, but often that is folks with additional risk factors. So for example, every incarcerated male, there is a recommendation to test for chlamydia and gonorrhea. And folks with other risk factors like homelessness or substance use or anything that's an indication for HIV prevention would also be an indication for routine chlamydia and gonorrhea testing. So the next group are folks who are living with HIV. There is, again, because HIV is often a risk factor for other things that put someone at risk for chlamydia and gonorrhea, a recommendation to be tested at least annually and at all body sites where someone can get sick. So a throat swab, a rectal swab, and a genital test, whether that's peeing in a cup if you have a penis, or a vaginal swab or cervical swab if you have a vagina. Patients on PrEP, which we'll talk about more in a moment, because of, again, correlation with very high risk, should get routine testing for chlamydia and gonorrhea at all exposed sites every 3 months. And then anyone who has been treated should be tested again 3 months later. And that's less because of treatment failure, although sometimes we do see treatment failure even though the treatments are very effective. But we also see reinfection really commonly, and that's really why we're recommending that repeat testing 3 months later. Also, anyone who's been positive must be at risk for the infection, and so we recommend risk-based testing for them. Next slide, please. In terms of syphilis recommendations, it's not quite as commonly recommended for routine screening because it is a less common infection, although it is the one we're most worried about here in Santa Clara County. We do recommend it because of those sexual orientation-based disparities we talked about, routinely for men who have sex with men, at least annually if they're sexually active at all, and up to every 3 months if they're at higher risk for any of the risk factors we talked about. Again, in correctional settings where we see very high risk of syphilis among folks, all are recommended to be tested. People with HIV, again, at least annually and up to every 3 months. Anyone coming in to an STD clinic or being tested positive or evaluated for any other STD is recommended to have syphilis testing. And then anyone who's pregnant, it's required by law in California and in most other places that at the first prenatal visit, everyone be tested. And that should happen in the first trimester. But if they miss that first trimester testing, then as soon as possible. Again, in the third trimester, here in Santa Clara County and other places where there's high risk, we recommend testing for every single pregnant person, again in third trimester. And then here in Santa Clara County, if they miss that third trimester screen, or if they have other risk factors personally, we recommend another test at delivery. And then anyone who delivers a stillborn infant should be tested as well. Next slide, please. But I do want to stress that as we talk about routine testing, a US study put out by the CDC found that 50% of pregnant patients with syphilis had no risk factors. And that's why we have these stringent recommendations for every single pregnant patient, because whether somebody isn't aware of their risk factors, chooses not to disclose them, or frankly doesn't have any, we know that there is still risk out there, and the benefit of testing someone early and treating them early with antibiotics so far outweighs the risks of not testing someone and missing this very potentially deadly or disabling infection. We want that routine testing. We don't want to wait to find out about risk factors in order to offer that testing. Next slide, please. I also want to point out, again, the recommendation for HIV testing, which I find to be a little bit confusing, but often folks have found ways to interpret it and standardize it in a really helpful way. There is a universal recommendation for opt-out, which means we don't wait for someone to say yes, we wait for them to say no. Opt-out testing for HIV for every single adult. And so then more frequent testing for anybody with any additional risk factors. And I think in that case, that's anyone who's sexually active should be routinely offered at least annually an HIV test. And then folks with other risk factors tested more frequently, especially folks who are on PrEP would be tested every 3 months. And what we found, fortunately, in our county is that is happening more and more often, that this testing is becoming routine. We aren't waiting until someone is incarcerated and diagnosing them in a correctional setting. We aren't waiting until they come to the emergency department. We aren't waiting until they're hospitalized with an HIV-related infection. We are doing routine outpatient testing. This is the norm where people get their HIV tests not in a special clinic, that SDR, Screening Diagnostic and Referral Agency, but are getting tested at their regular doctor's office because this is where routine preventive care happens, and HIV testing is a part of routine preventive care. Next slide, please. So here's where we are with HIV that is so wonderful compared to where we are with COVID. We used to have to rely on behavioral preventive techniques, telling people to change the way they have sex, change who they have sex with, change how they have sex, and use condoms every time. And that was really our only option. We had limited treatments, but because of their toxicity or limited availability or cost or inconvenience, we really waited until people were getting really sick from their HIV before treating them. And we had a lot of barriers to treatment, whether that was stigma or access to affordable care or the ability for routine providers to start somebody on HIV treatment, a lot of barriers to getting on that treatment. We knew that the infection itself was reducing people to lifelong risk of transmission to their partners, and that early on, we knew that everyone's life expectancy was going to be impacted by their HIV. Today is a completely different world given those biomedical interventions that we have. We have PrEP and PEP, and we'll talk about that in a moment. Medications that used to be used only to treat HIV, but now are used to prevent it. We have same-day treatment initiation, where we have treatments that are so safe, so effective, so easily accessible, and so routinely and sort of uniformly prescribable that we don't need HIV-trained specific doctors to start them. Any primary care doctor can start somebody on HIV medication, and there are systems and routinized way to help people do that so that you don't have to know the details of every HIV medication. You can be part of a practice where there's an order set that you're effectively using to go ahead and get started on HIV treatment. And we do that same day, not just because of the health benefits, but because of the transmission benefits. where we know now that people with HIV who are effectively on treatment to the point that their viral load is suppressed are not able to transmit as HIV through sex. And with this and the wraparound services we provide to help people overcome any barrier to getting on and staying on treatment, we now see equal life expectancy for somebody diagnosed today with HIV as somebody not diagnosed if they have other equal risk factors. Now, given all of those other social determinants we talked about that put people at risk for HIV that also impact your likelihood of dying from heart attacks or cancer or violence, we do see overall different life expectancy for the community with HIV compared to the community without HIV. But that is not because of HIV itself. That's because of everything else that surrounds that person. And if we overcome those other social determinants of health, HIV is not only not a death sentence, it is a completely overcomable chronic disease that with minimal day-to-day changes in someone's life can completely not impact their health outcomes. So going to the next slide, please. Here's where we're going to talk about PrEP, PEP, and what we call ART, antiretroviral therapy. So the only difference is we use the exact same medications at different times in the spectrum of exposure to infection. The same medications we use for therapy, for treating people with HIV to help them survive, maintain their immune function, and reduce their risk of transmission. We can also give at the moment someone gets exposed or shortly after, which we call post-exposure prophylaxis, PEP, or we can give prior to exposure, before they're ever even exposed via sex or a needle stick or anything else. We give the same medications as pre-exposure prophylaxis, or called PrEP. Going to the next slide. So again, this is this powerful biomedical intervention that we wish we had something equivalent for COVID, and we are so fortunate to have in the HIV world. Right now, and I apologize, there are actually 2 FDA-approved medications, and I didn't realize I included an old version of this slide. So as many of you know, in addition to Truvada, we have Descovy as well as an FDA-approved medication for pre-exposure prophylaxis, which that Descovy approval is specific for certain populations, but both of these are a 1 pill, once-a-day regimens that once taken for a period of time, prevent people from acquiring HIV if they're exposed. And if taken every day, have a 99% reduction in HIV transmission risk. There's also an extremely low risk of side effects and adverse reactions. And most of those side effects are things like startup syndrome, where people can feel sick to their stomach or have some diarrhea. But most of that is limited and will go away for people even if they keep taking the medication. Next slide, please. One of the additional benefits of PrEP and why it's so important to return to that idea Atul Gawande was talking about with respect to COVID of integrating our therapies, or our amazing listener who was talking about integrating COVID testing with STD and HIV testing. We already have recommendations to integrate STD testing and PrEP care. And by integrating prevention of HIV, which we know there's a huge demand for, people are really interested in, with routine standardized STD testing, we've actually found that not only is PrEP not likely to increase risk of STDs, but there's a possibility PrEP care, because of its integration with STD testing and therefore faster access to treatment and reduced risk of passing chlamydia and gonorrhea and syphilis to their partners, PrEP care can actually reduce overall counts of other non-HIV STDs, in addition to the STD it prevents on purpose, HIV. Next slide, please. In addition, we talked about post-exposure prophylaxis. So this is using a combination of medications at or just after the time of exposure for prevention of infection. And so it does need to be given within 72 hours of that exposure, which is why we prefer people take PrEP if they're eligible for it, if there aren't medical contraindications, because an ounce of prevention is worth a pound of cure, and because some of the barriers to accessing PEP rapidly, needing to get to a doctor or nurse or pharmacist and do it quickly, recognize that the exposure has happened, aren't needed for that preventive care when you take the medication before exposure. Next slide, please. So in the recommended PEP regimen, we do see that people benefit from starting it right away. The slide or the graph on the right shows that and this is in a monkey model, we're able to reduce the risk of transmission dramatically by about 50% if we start within 24 hours, and effectively down to 0 if we started this regimen within 24 hours and continued it for an entire month. So that rapid start is really important, and we don't even want to wait 24 hours. We would like the first dose to be given within 2 hours of an exposure whenever possible. So we don't even wait anymore to make sure that the person somebody had sex with actually had HIV. We don't worry about the source patient testing up front. If there's any risk that somebody had an unprotected sexual encounter or other exposure, like shared needles or a penetrating injury with blood exposure, we don't wait to find out for sure that the person they were exposed to had HIV. Unless we know they're HIV negative, that source patient, we're going to go ahead and recommend post-exposure prophylaxis to the exposed person. Start it right away and make sure that they're getting a regimen that's easy to take with minimized side effects and adverse events and risk factors, and cover the usual transmitted resistance patterns. So if we go to the next slide, those specific recommended regimens, which are actually expanding considerably as well. Usually these days are Truvada and either Icentris or Tivicay, either raltegravir or dolutegravir. And we prefer dolutegravir in anybody who could, we prefer raltegravir in anyone who could be pregnant because of a small risk related to pregnancy for folks taking dolutegravir. So this 2-pill, either once a day or twice a day regimen, because the raltegravir is twice a day, taken for 28 or 30 days, has an incredibly high efficacy at preventing transmission after somebody's exposed. So next slide, please. And I want to say that we are flying through PEP and PrEP as interventions here. Many of you know that there is a lot more to be said about PEP and PrEP, and that's forthcoming in the rest of these webinars. There is versions of PrEP where you don't have to take it every day. There are new regimens available for PEP. There's a lot more happening here that you're going to hopefully sign up for our next webinar and learn all about. But the piece I want to point out today here is, again, that integration of PrEP care and PEP care becoming routine, becoming part of primary care, becoming something somebody is offered and doesn't have to go seek out themselves, and integrating it with routine testing like hepatitis C screening, hepatitis B testing and vaccination, hepatitis A testing and vaccination, and other STD testing. All of that lumped together, made easy for the patient, made routine, is what helps make sure that our clients get the care they need with the least barriers in a way that really takes care of this epidemic and has the power to reduce that scary uptick that we've been seeing for a long time in the STD world and the disparities that we've been seeing in the HIV world, without, again, waiting for folks to come to us and ask for it. So if we go to the next slide, one of those major interventions, so this is just highlighting here that, again, including those other tests and preventive techniques in PrEP care is part of what makes it so powerful. And to clarify for one of our questions that came through, I want to be clear, we do not have suspicion that PrEP medications prevent bacterial STDs like chlamydia, gonorrhea, and syphilis. Instead, we think that the healthcare people get and the way that they access STD testing early and often, and the treatment that comes with being diagnosed early, and the prevention that comes with being diagnosed and treated early, that's what helps PrEP care, helps potentially reduce STD transmission, even though the PrEP medication doesn't stop the transmission of those other STDs. So next slide, please. One of the things that I think is so powerful, another tool we're using in the COVID world, and that I think really helps to overcome barriers to PrEP and PEP care for our partners and for our patients, is if healthcare providers set up order sets. This is something we've done in the county and helped other non-county entities that we partner with to do. Set up what's almost sort of a one checkbox to do everything a provider needs to get somebody started on PrEP or PEP. So that includes helping to fill out the doctor's note and nurse's note, helping to create all the right lab test orders, helping to create the medication order, including for PEP, that first emergency dose that we want given in an emergency department or in an urgent care setting the second somebody shows up, providing all of the patient education, providing the right diagnosis code so that all of the billing happens appropriately, and that the patient gets low likelihood or no likelihood of having to pay for parts of this service. We have helped people bundle this all together to make it easy for providers. We're doing the exact same thing with same-day HIV treatment as well, what we call rapid ART, rapid access to antiretroviral therapy, where a primary care provider with no particular expertise in HIV, if they diagnose an HIV patient in their practice, can go ahead and order all the right tests, give people all the right initial education, make all the right initial assessments about what treatment's going to be right for people, and then go ahead and order the right medications all at once and get people lined up to see an HIV expert as soon as possible, but without having to wait for that HIV expert consultation before we start HIV care. And again, we know that that has huge benefits for folks. We go to the next slide. Did we skip one? There we go. Oh, sorry. So I want to touch on, this is one more reason why that rapid start of HIV treatment for somebody who is diagnosed, so we've moved from talking about prevention to treatment, is so important. It is not just about the survival of people living with HIV, but about their loved ones, their sex partners, their needle sharing partners as well. That we have known now based on decades and decades of data, that people who have HIV but who take medication every day to the point that their viral load is undetectable. When we check their blood for virus, we don't find it based on usual standard tests, even though we know it is still there since we don't yet have a cure for the infection. Those folks on medication until they're undetectable are untransmittable. They having sex with their partners, even without condoms, even without the partners on PrEP, have effectively zero risk of spreading HIV. And you can imagine this is life-changing for people who are living with HIV, especially those who have been for a long time, that understanding they, by taking care of their own health, are also caring for and protecting their sex partner's health. Because so many of us are more inspired to do things to protect our loved ones than ourselves. You can imagine how incredibly important this is for folks who may or may not make the choice to care for their own health care, but now have the option to make that same choice and help themselves while protecting their loved ones. So going to the next slide. What we really want folks to move towards doing is this rapid initiation, because we found that the new medication and regimens are so easy to take, so affordable, and so safe for basically everyone, even with very severe HIV infections or most co-infections and comorbidities, that almost every single HIV patient is recommended to start treatment right away. And we've been able, with that knowledge of how safe this is, to streamline the clinical assessment, streamline the counseling a person needs in order to start medications, simplify their regimens with usually one pill once a day for everyone. And this gives us not only that faster time to undetectable and therefore untransmittable and reducing transmission of HIV, reducing our community burden of HIV, but it also has huge benefits for the health and safety of that individual starting medication right away. There is better immune recovery, better adherence with medication over time, and just sort of a huge bevy of evidence showing us that people stay on medication longer, and almost every aspect of their immune system and all of the downstream effects of that improved immune system are benefited by starting right away, even compared to delaying 2 weeks or a month. Now, we do still have barriers to doing this. Sometimes folks will have health insurance or completely no health insurance, such that they are able to seek that HIV testing, able to be sitting in front of a provider who could start them, but not be able to afford the medication. So there are still instances where we work with folks to help provide that. And at the very end, we'll show resources specific to Santa Clara County for where, if you practice here, you can help get assistance from a group called Positive Connections to overcome those barriers for your particular patients, where we can get rapid free access to medication, rapid enrollment in specific types of healthcare coverage and medication pharmacy coverage that will cover any cost of testing, healthcare, or medications that folks may be struggling with. But really, our barrier has been provider uptake, has been helping convince primary care providers and everyone who works with them that this is the right thing to do, that the benefits outweigh the risks, and that we can make this easy and safe for you to do in your practice. And so we are very excited, and I see there's already interest about how to do things like set up those relationships in your local area with community providers who are HIV experts who can help support you in this, or with your local health department. And here, if you're practicing in Santa Clara County, we want to help you do this this in your clinical setting as well, including working with you to help set up those order sets. Next slide, please. So I want to talk about our Getting to Zero initiative here. I know we've got a lot of questions. We still have 45 minutes, and so I think we're leaving a fair amount of time for questions. So I'm going to run through what we're doing here to try to embrace what we've learned from these decades of HIV response, decades of STD response, centuries in some ways, and even the lessons learned once again from finding those same things when we respond to the COVID pandemic. And these are thinking about cross-collaboration across sectors, routinization of testing and treatment and prevention options, and then understanding the impact of social determinants of health on people's risk for getting HIV and STDs, on being able to access the treatment and prevention they need, and on thriving and having reduced impact of those diseases once they do have them. So here in Santa Clara County, we call this Getting to Zero. We'll go to the next slide. So our initiative here in Santa Clara County has been what we call a collective impact model, where we have tried to bring together representatives of almost every sector who may have some impact in what we just described, whether that's working for a community-based organization, a faith-based organization, being a clinical care provider, being a patient or patient advocate or other person impacted by HIV, or being a member or a community-based organization representing any of the communities we've talked about that have been disproportionately impacted by HIV and STDs. We've worked to bring those folks together and have set 4 priority strategies to help overcome those rising rates of STDs you've been seeing and those ongoing, persistent, and in some cases worsening disparities in HIV risk and outcome. We have worked on increasing access to PrEP and PEP. We've worked on increasing routine guideline-based testing for STDs and HIV. We've worked on enhancing linkage to HIV care for people who are newly diagnosed and retention in care for people who are already diagnosed, making care easy, affordable, and supported so that all of the things that might make it hard to stay in care, like becoming homeless or losing your job and insurance, or having major healthcare impacts from COVID or from the pandemic-related economic downturn, that we have systems in support of all of those problems to help overcome the barriers, whether that's transportation to your doctor's appointment, systems to afford healthcare, food delivery, or case management to help access a wide other array of support services. And then finally, understanding the impact of stigma and the way that HIV risk and other STD risks are inextricably related to racism and homophobia and transphobia. We understand that we need to directly acknowledge and respond to stigma associated with HIV itself and with being part of these disproportionately impacted communities. I think another huge one is people who inject drugs or use other drugs of abuse. Supporting folks who inject drugs and supporting the stigma related or response to the stigma related to that substance use, and help make sure folks who use drugs and especially who inject drugs have the same or better access to services as everyone who doesn't use drugs or doesn't inject drugs. And understanding how stigma plays in there has been a key piece. That's one more parallel to our COVID response, is that we need to take that same harm reduction approach, thinking about what is this one person able to choose on their day-to-day, and therefore what services and resources do we need to offer that particular person to support them. So going to the next slide. We've actually got a lot here. We may kind of fly through it and then circle back if there's specifics we want to touch back on. But I want to talk about how we've tried to do that here, and then hear what questions you have, hear what excites you or what you think would be borne out in your particular role or your particular community, and then what questions you have. So next slide, please. Here's what we've tried to do over the last 4 years as we built and tried to strengthen our own Getting to Zero impact. So we first convened those key stakeholders even before launching the initiative itself to say, what is this going to look like and who needs to be at the table? We created a planning council even before the official launch in early 2016, hired a PrEP navigator to help think about barriers to PrEP access for folks and build a system that would help overcome them, and build those priority strategies we just discussed. We hired additional specific and county resourced positions like a health education specialist. And around that time in 2016, the county did, I think, one of the most important things, which is the county itself dedicated several $millions to this venture over this next 4 years. To say that this is so important to us, this kind of cross-sector collaboration that addresses HIV and other STDs at every level of how it impacts communities, understands which communities are being disproportionately impacted, and looks to those communities to decide for themselves and tell us how we needed to respond. That kind of work needed an upfront infusion of tax dollars straight from the government. And that was done here as an initial investment that has borne out not only in our response funded by that investment itself, but in-kind support and additional external investments that came in to match. So throughout 2017, we were really focused on pulling that network together and launching a mini grants program. We're using some of that initial county investment. We gave small amounts of money, often $10,000, I think at most $50,000, to organizations that were already embedded in the community, already had deep ties to the same folks who were being disproportionately impacted by these outcomes, to say, what do you need to do the work that you feel you need to do to make a difference in our 4 key strategies? And we've done that every year since the beginning of the initiative and seen amazing work come out of it. Everything from a telenovela in Spanish, sort of really normalizing conversations around PrEP and HIV care and treatment, around outreach campaigns specific to African American and African ancestry populations. And then there's also been a separate significant investment in community designed media campaigns, whether that's mostly social media or some traditional media, things like billboards and ad buys and radio. We have hosted events like World AIDS Day and outreach events at universities and at Pride, a whole host of things that we think have really pulled community into being part of this conversation. We started what we call academic detailing, which if you're a practitioner here in Santa Clara County, we would love you to remotely, but we previously in person went to doctors' offices, talked to them about things like PrEP and PEP and routine STD screening and syphilis treatment and rapid HIV treatment eventually, to see in your particular clinic, what would that look like and what do you need to get there? Do you need help with designing automated computer systems? Do you need help understanding how your patients can afford the medications? Do you need specific education for your front desk staff or for the nurses or for the doctors themselves or nurse practitioners, physician's assistants? What do you need in your particular setting to help improve your practice and improve the care you're giving your patients and clients? So we'll go to the next slide. Excuse me. We've also brought in a massive number of collaborators, both the initial folks who sort of self-identified, or we were already in partnership with them before this initiative, folks who were our HIV care service providers, or who had specific ties like our local LGBTQ community center. But we've brought in both via those mini grants, understanding that community-based organizations do need infusions of funds in order to do new work. And that in order to not only reap the benefits of such community organizations, but to sustain them and to value the communities themselves that they represent, we need to pay them for their time and their hard work. And so with these mini grants, we've been able to bring in a massive additional group that I think we wouldn't have been able to otherwise. Whether those were clinical partnerships or, for example, an amazing group called Caminar that runs a queer youth space, university and other academic partners. By issuing those mini grants, that's how we've been able to bring in folks who otherwise just frankly wouldn't have the bandwidth or the resources to do additional work to support this venture and collaboratively support the communities we're all focusing on. We also had some paid contracted partners, things like our advertising design and dissemination firm, Better World Advertising, a group that helped us with our evaluation, John Snow, and Bill Wilson Center, another community collaborator focused on outreach. So next slide, please. And again, that initial massive investment of the county general fund year after year after year was able to help us leverage additional funds, whether that was grant funds we already had, which we could link in to do this work collaboratively and show that it's all kind of the same work between things we were doing with other grants. Additional grants we were able to apply for and successfully receive because we had made this initial infusion and started the work that proved we were capable of doing more if funded further. Additional decisions that we were able to pull other grant funds to focus on this work once we showed how meaningful it was, what engagement there was, and how well structured we were. And then additional external partners who were able to donate funds, again, once we had made our own initial investment and showed how important that was, how much we valued the work we were doing in the communities we were attempting to serve, that those same communities or other local partners were able to donate as well. Next slide, please. And again, through this, we have seen massive improvements and massive amounts of work happen. I'll just touch on a couple of key things. So with that brand new PrEP navigation program that was served that helped individual clients figure out how they were going to get to a doctor or nurse to give them PrEP and how they were going to pay for it and how they were going to sustain on it and answer their questions about it. We have served, this is now well over almost 500 clients. We added PrEP navigation in other settings. We added automated access to PrEP and PEP in our pharmacies associated with the county healthcare system. We built those PrEP and PEP order sets in our county system and have helped outside systems try to do that. We've done extensive trainings on PEP and PrEP. We've added a pharmacist who sees her own panel of PEP and PrEP patients, and with that demonstrated that not only do you not need to be an HIV expert to provide PEP and PrEP care, not only do you need to not be a doctor, nurses and nurse practitioners and physician's assistants are some of our absolute best PrEP and PEP providers because often your training is so strongly rooted in utilizing protocols and applying to their patient populations. And then we found that pharmacists are another amazing untapped resource with this process, and that pharmacists can see their own PEP and PrEP clients and provide really high quality, important preventive care. And so with that demonstration, we were actually able to use our own resources to support the new California law that went out about a year ago that allows all pharmacists across California to train and then provide certain types of PrEP and PEP services. And then finally, we've worked with another group of key partners in homeless and unhoused care and our jail reentry services to provide universal screening so that every patient who walks through there is offered PrEP or assessed to see if they would benefit for PrEP and have interest in it and any risk factors that would limit their access to usual PrEP care. And then we talked about the academic detailing program where we go out and support individual doctors' offices and clinics, and then added a vast number of new clinical providers in their ability to offer PrEP to a website called Please Prep Me, where folks can find a provider near them based on folks who have stated that our clinic or our service offers PrEP. Next slide, please. Again, we've talked about these amazing social marketing and media campaigns that we've had. Here are two examples, one called PrEP is For, where we detailed all the different kinds of people that PrEP is appropriate for, because really PrEP is for everyone. If anyone is sexually active, if anyone has used needles for any reason, PrEP is for you, and we can find a version of PrEP that's safe for you and effective for you. So PrEP is for couples and PrEP is for singles. PrEP is for people of almost any identity. And so our PrEP is For campaign used local models, including some folks we knew well, to advertise all the different people who PrEP can be of benefit to. We also had one of our key partners, the Roots Clinic, who serves especially African and African ancestry populations, but serves all populations in a federally qualified healthcare center. Another specific community developed and community disseminated PrEP awareness campaign. Next slide, please. We've also worked to enhance STD and HIV testing through, again, that same routinization, understanding that having conversations with your clients and patients about their risk factors is key to understand those social determinants of health, and doing so in an open, affirming way that's respectful of all identities and uses modern language that displays that respect is still important. But making testing available to everyone, screening available to everyone in a routine opt-out way, and then tailoring it to someone's specific requests and needs is going to help us make sure we don't miss people, that we don't stigmatize people for those risk factors, and that we don't have to wait for people to ask for something. We're there to proactively offer it to them. And we've worked to standardize this across a wide range of settings in our Getting to Zero initiative by bringing folks in as partners directly into the initiative or reaching out to folks who weren't already part of the initiative to see how we could serve their setting. Next slide, please. We've also focused on linkage and retention, as we talked about, with another specific ad campaign talking about how that untransmittable, undetectable equals untransmittable finding is so important for the HIV community. And while this says this has been forthcoming, it is now disseminated, and you can find it on our website. Next slide, please. We've had additional stigma reduction activities as well, and we talked at the beginning about how important that is, both ad campaigns, this telenovela that we've talked about, the undetectable equals untransmittable campaign we talked about, and now most recently a study looking at stigma as it's borne out in HIV care settings and how we can address it there to make sure that folks living with HIV have as close to a stigma-free environment as possible when they seek HIV-related care. Next slide, please. So to wrap up here, and then we've still got about half an hour for discussion and questions. I just want to go through a couple of key findings and then a couple of specific resources. Next slide. Some are specific for Santa Clara County, and some hopefully will be useful to you wherever you are. So we talked about how the future of STD and HIV depends on barrier-free access, stigma-free access to testing and biomedical interventions. For HIV, that's PrEP and PEP and rapid HIV treatment initiation for folks who are HIV positive. For STDs, that really is treating the STD as quickly as possible, which means diagnosing someone as early as possible, which not only benefits the person with an STD to reduce their risk of complications, but benefits their sex partners by reducing risk of transmission. We've talked about how integrating across partners, in the case of STD and HIV care, that's primary care, and integrating all of these elements of testing, treatment, and prevention into primary care, including not even care settings, things like pharmacy offices or even retail pharmacies or community settings that aren't normally providing healthcare. By that integration, we both help to overcome the stigma by making this a routine, just part of everyone's day. Is at some point we go to the dentist and get our teeth cleaned. At some point we go to the doctor, or we go to our routine, our community health center, or our LGBTQ center, or whatever our community-based organization is, and get our STD testing, get our HIV testing, get our PrEP care. We've talked about how automation and integration of these different types of services both help to overcome stigma and help to avoid missed opportunities for testing, treatment, and prevention, and how we're here in Santa Clara County to help you overcome that. And some of the focus of these future webinars are going to talk about the details of those services. And then how the COVID-19 pandemic has reinforced all of these lessons that we've learned in the HIV and STD world, how important cross-sector collaboration is, how important access to testing and routinization of that testing is, and how important social determinants of health are, both in understanding our clients, why they're at risk for the diseases they're at risk for and the outcomes they experience, and how it's our role to address those social determinants when it comes to their health care and health prevention, but then also any role we can find ourselves able to play in reducing the social determinants themselves. So those last two slides of just resources we'll focus on, and then we'll take questions. So here in Santa Clara County, you can actually go to the next one. I just want to make sure folks know what the STD and HIV program does here for you if you're here locally. So we provide some direct STD and HIV care services, some treatment, some testing, and some PrEP and PEP in a clinic that's open 3 half-days a week, and then an additional self-testing clinic some additional days. There have been some changes related to COVID, and that's up on our website. We do traditional disease control, that same contact tracing that we're all talking about with COVID. We do that for all other STDs as well. We do a large amount of HIV care and support access. We operate our local Ryan White program, which means that we help people not only access HIV-specific healthcare and mental health care and medications, but we also help them access things like case management, food, transportation, legal support, financial assistance, everything you can imagine somebody living with HIV might need to overcome any barrier to staying in and succeeding in their HIV care. We offer STD prevention. We talked about harm reduction approaches to folks who inject drugs, and we offer a needle exchange that both helps to get used needles off the street and give people access to safer injection supplies. We offer specific opioid overdose prevention in that context, clinician education, and PEP and PrEP navigation for clients. And if you go to the next slide, we're in the process this year of building out a hepatitis C prevention and control program as well. That is brand new. We're just working now to hire our first ever employee, where we hope to investigate acute diagnoses, people who are newly ill with HIV, and offer contact tracing in those cases, offer case management, especially to pregnant cases and some other specific circumstances. And then most importantly, in addition to a lot of the hep C screening we're already doing, we want to be able to link people to hep C care and support them through that care the same way and in parallel to how we do it with HIV. Next slide, please. So these are specific contacts. Oh, and I apologize, this is a slightly outdated version. Sadly, our nurse manager has just left our program. So I'll remove that last phone number for you. We're very sorry to see Cherise Feldman move on to her next amazing role with public health. But here's my contact information. And for those of you who are local, I really do encourage you to reach out directly if I can help you with your practice or your community setting. But up top are all of our specific phone numbers for the various services we described. With communicable disease investigation, we can help with partner services, we can help get people access to care and treatment, and we can help you locate clients if you've diagnosed someone or are aware of their partner and are unable to find them. For people with HIV, that Positive Connections program that helps people overcome some of the cost and other logistic barriers to getting started and staying in HIV care, that phone number is for those folks. And then in terms of HIV prevention, we've got a PrEP and PEP navigation team at that phone number there. I'll go to the next slide. We'll leave this one up, but again, all of these slides will be emailed out to you. So these are nationally available and internationally available, but US specific resources for the CDC's STD treatment guidelines. It is available in the version of an app that I find myself checking regularly, even though I do this all day, every day. So I definitely would recommend that everyone go ahead and download the CDC STD treatment app so that you can double check, how do I treat that tricky gonorrhea test, or who is it who's recommended to be screened for syphilis regularly. We do anticipate update to the guidelines in the next year or so stay tuned for those as well. But the current guidelines are still valid, are still recommended, and so feel free to continue following those. So I think we'll leave this slide up so people can continue to access that. But I think that's everything. I want to thank Carlos, who helped prepare this, and Lori Osorio, who some of you see on there as one of my colleagues in the prevention and training world. And we have plenty of time to answer questions. I see some of my own team is logged in and answering questions in the chat as well. So I appreciate you helping out with that. And I'll try to take as many questions I can in the next half hour. Thank you.
Thank you, Dr. Rudman. And I am sure that if we were in a different world at a conference in real time, you would have a standing ovation. That was brilliant. So I have several questions that were sent to me in the private chat. I want to start with those because they came in early. The first question I have is, how does gender-based violence and race play a role in congenital syphilis and the increase in other STIs generally?
So that's an incredibly important question. And I think probably the answer is there is almost no part of the STD and HIV spectrum, from risk to accessing care to successful treatment to all of the health outcomes related with these infections and all of the stigma and other downstream non-medical complications of the infections themselves, the cost, the the inconvenience that are related to gender-based discrimination, gender-based violence, structural and interpersonal racism, and race-based violence. And again, the overlap with incarceration that we talked about is one example. I think it plays in the ways that those indirectly affect poverty and access to healthcare, the way that people are treated in the healthcare system or are afraid of being treated and therefore limit their care, the way that people have the ability or not to decide when they have sex and with whom and if they're going to use a condom. We hear very frequently about, for example, trans women and cis women who are unstably housed or don't have access to reliable income in their own home, who use sex to be able to be safe wherever it is they're living, to have access to somebody who's going to protect them physically, have access to a substance they're using or maybe addicted to, or just be allowed to stay somewhere, that they are exchanging sex for the right to have a place to sleep. And while we do everything to combat that at the level of finding people other safe places to stay, finding people the resources, finding people the healthcare, finding people the money, finding people the substance use treatment, we also try to combat this at the STD care and treatment level, where we understand that for some people right now, the way they have sex may not be something that's going to change, because in order for it to change, they would need a new home, or they would need to be able to escape a violent partner, and they're not able to do that safely right now. And so instead, that harm reduction principle guides us to see what is the next best thing. The next best thing may be access to very frequent testing. There are folks we test for other bacterial STDs every month. We test for HIV every month to make sure that we catch people and get them on treatment as quickly as possible. There may be folks, for example, where it's not safe for them to have their HIV medication at home because they have a partner who would be violent towards them if they discover their HIV status. And so we help to get them their HIV treatment at their methadone clinic. It may be folks that we are unsafe carrying large amounts of condoms because they might be arrested on a prostitution charge because they are a sex worker, or are exchanging sex in other circumstances. And so we try to offer them frequent access to low numbers of condoms because they don't feel it's safe for them to carry high numbers. So whatever it is that somebody needs, we try to address that particular need as described, as endorsed by the patient, while constantly being a messenger about how prevailing this system of gender-based and race-based violence and structural racism and structural sexism and transphobia are impacting these folks, and how tightly knit that that relationship is with HIV risk and STD risk, and how you just cannot separate the two, or the three in this case. I've probably just scratched the surface about all the ways structural racism and gender-based discrimination affect everything we're talking about. We haven't talked about employment. Yeah, there's a lot more there. I think the big message is the integration is probably something we may never separate. And so we have to constantly attack on both fronts, talking about racism, talking about gender-based discrimination, talking about how that affects all races and all genders, talking about how dominant races and genders are still affected negatively by those systems, and talking about how we need to combat those axes of discrimination at the same time that we acknowledge they exist and serve people experiencing every component of it everywhere that they tell us they need to be served. Excellent question, thank you.
So to be fair,
I want to acknowledge a really important point that was made in the chat box. That trans men and other trans masculine folks and non-binary folks are, I'm remiss in having not called them out specifically as a group that is dramatically disproportionately affected by gender-based violence, gender-based discrimination as it applies across all fronts: employment, housing, access to healthcare, and therefore, and separately as well, as it affects risk of HIV and negative HIV outcomes and other STDs. So thank you for that comment.
Thank you, Dr. Budman. To be fair, what we'll do is take one that was sent to me privately and then one that was publicly posted. So the next question I have, it comes from our friend Pamela, and I'm guessing that I can say her name out loud because she posted it publicly. And Pamela asked a question in relation to her work with HIV, the transitional youth, and she tests them quarterly, and STI is very common. syphilis is very common with her clients in San Francisco. And can you tell us a little bit more about perhaps how to work best with these transitional youth?
So it sounds like Pamela may be much more of an expert than I am, but I'll tell you a couple of things that I want to call out when it comes to caring for transitional age youth and other adolescents and youth. I think in general, first, it's really important for folks to acknowledge the medications we have, those same recommendations we talked about, are safe and effective in youth. We know specifically that Truvada and Descovy are safe and effective in youth. We do know that there is some risk of decreased bone density in general with Truvada, and there is some concern that that may affect folks with growing bones more than folks whose bones have stopped growing. But in general, we also have enough data to tell us that A, there are not fragility fractures in youth associated with that bone density change. So no one's ever had a broken bone from Truvada, or no one from Truvada for PrEP. And then we know that that bone density can completely revert to normal expected bone density if somebody does take a break from their PrEP. So these medications and recommended preventive and treatment techniques are all equally safe in youth. We also, I think it's really important for everyone who doesn't routinely work with youth to know that youth ages 12 and up may consent to all of their own services when it relates to HIV, STDs, other reportable transmittable diseases. So that includes COVID. Youth age 12 and up may consent to their own COVID testing or COVID related care. Those same youth may consent to their own treatment related to substance use and any care related to pregnancy or pregnancy prevention. So that's important to know if you don't routinely work with those folks, that not only do you not need to seek a parent or guardian guidance, but in most circumstances, discussing with a parent or guardian without the youth's express permission is illegal. So thank you for acknowledging the independence of your youth. Often we find, especially with the same youth who are at risk for HIV and other STDs and pregnancy, they may be in circumstances where involving a parent or guardian in their care is not safe for them and decreases their safety as opposed to increasing it. While we always ask a youth we're working with to identify a trusted adult who we can try to involve in their care when that's safe and appropriate, we also empower them and acknowledge their rights as consenting minors to certain types of care to not involve an adult, especially not a parent or guardian, if it's not considered safe or not what they want at that time. Other things in terms of working with youth, I have to say it's probably not as much my area of expertise as some other folks will have on future webinars. But I do want to touch on that those same recommendations for routine screening we talked about, especially chlamydia and gonorrhea, apply in youth because we see some of our highest numbers of chlamydia and gonorrhea in youth, especially the 25 and under range, but also in the 17 and under range. And then we also see, again, youth with any additional risk factor, whether that's demographic based on gender or race or ethnicity, or whether that is structural based on housing status or family income. We do see increased rates in those folks as well, and want to make sure they're getting the same easy, routine access, normalized access to screening and treatment that we talked about for adults.
Thank you. The next question I have is, there been an impact on STI screening in prisons as a result of COVID-19?
We think so, yes. I would like to say that our March, April, May apparent drop-off in syphilis and gonorrhea rates was due to real decreased transmission, but I frankly don't have enough evidence to believe it. I think we did see a real dip in how much people are testing. And I think that that was because it was difficult for us as we were scrambling to respond to the COVID aspects of the pandemic and the economic aspects of the pandemic to think about all of the other preventive care that was going by the wayside at that time. We are still playing catch up there, doing things like figuring out how to mail people test kits at home on a regular basis and get them back and run them and get them their access to their results and their access to treatment. Figure out how to open up preventive care settings fully to the extent we had them open previously, thinking about how to transport people to care if their usual means of transportation are not available or are not safe because of COVID. So we're still figuring out a lot of how to do that well. And I think we're going to see in a negative way an effect on all STDs because of the pandemic, not in a positive way. There is a possibility, and we frankly don't know, that the same social distancing and other reduced mobility that we've seen in order to prevent COVID, it might have some benefit on STDs in some sectors. The reason I say that is because we do know from some data that our recommendation to shelter in place was followed as much as possible by most people. And that may have included not doing things that in other settings led people to have sex, especially sex with new partners, things like going to bars, for example. But because of all of the other negative downstream effects of the pandemic itself, you can imagine this being everything from my partner or family member died because of COVID, and I am seeking a new partner in that setting, or I'm open to a new partner potentially, or I've lost my job and have lost my healthcare access and won't have routine access to PrEP, or I was on the edge of being homeless previously, fell off that edge in the context of this economic downturn, and I'm now homeless and I'm now using sex for a place to stay. So all of these factors that we know are so tightly linked with HIV risk and STD risk and being able to access treatment and prevention and testing, those are all going to get worse right now for a lot of people, and almost exclusively for the same people that they've already been worse for: people of color, transgender folks, people living in poverty or on the edge of poverty, people living in dense housing, immigrant populations and their, people whose parents and grandparents are immigrants, and especially our undocumented populations. They are all going to be harder hit by every single aspect of this pandemic, not just the disease itself, and likely their risk for all of these downstream health effects are going to go up. And my concern is I think that increase in risk is going to outweigh any decrease in risk we saw from people having less sex during some of the risk reduction. So I'm worried about that. I'm thinking and spending our time talking to my team and our community partners about how we can be poised to respond to that. And I'm very open to input from any of you to tell me how to do that well here in Santa Clara County, or how to think to get in touch with the right folks wherever you are working to make sure it's done well there. Such an important question. I feel like there's a lot more to say there, but I want to try to answer one or two more questions in our last 10 minutes. Carlos, what else do we have lined up?
Yes, Dr. Rudman. Yes, we probably have just time for 2 more questions, but in terms of process, we will share the questions with Dr. Rudman and the rest of the GTZ team, and we promise to address those questions. We just have a lot of questions. So Gary writes, working in a free clinic, I've seen barriers to affordability of treatments and recommended screening for our at-risk patients, especially among non-English speaking individuals. How is the county follow-up, like at Santa Clara Valley Medical Center, handled for HIV/STI patients identified through nonprofits and free clinics?
Sure. So fortunately here, I'll speak to that locally and then see if I can address anything for folks outside of our immediate area. We have really fairly vast resources for Santa Clara County to help overcome those barriers. That's everything from the small clinic that we operate, which offers PEP, PrEP, all STD and HIV testing, and all bacterial STD treatment, is completely for free for everyone, regardless of documentation status, insurance status, etc. So if somebody does not have another place to go or can't afford whatever is offered to them in another location, we can treat you here. We often also have the ability to bring medication specifically for syphilis. So the type of penicillin, bicillin, that's needed to treat most syphilis infections. There's often a very high cost barrier to accessing it. This is a huge frustration and one that I think needs to be addressed on a statewide and national policy level. But for now, we are sometimes able to overcome that either by treating your patients here or by bringing you free or nearly free medication to your clinic to administer if that person's insurance will not cover the cost of medication at the price at which you have to purchase it. We're able to do that for some other medications as well. We're also able to do things like call in a prescription at the cost to the county if they fill it at certain pharmacies. When it comes to HIV treatment, we fortunately, because of the breadth of the Ryan White system and the ADAP, AIDS Drug Assistance Program, are able to help basically everyone of any income level, any documentation status, access treatment if they have any residency here in Santa Clara County. And that can be an attestation that they're sleeping in their car and their car is parked somewhere in Santa Clara County. That is sufficient notification for us to be able to enroll them in a system that can pay for every element of their HIV-related care and support services. When it comes to PrEP and PEP, for the medications themselves, there are a wide array of payment options, including programs that come from the companies that make the medications themselves. And as one of my team members mentioned in the chat box, we did see Truvada's patent expire yesterday and expect to see the market hopefully flooded with generic, very low cost options for PrEP imminently. It might have happened today and I just haven't heard about it yet. And I'm seeing a link that I can reference here as well. We'll work to share that for everyone. So we at the county, if you are encountering a barrier for your client you have not been able to overcome, please do give us a call. If it's a PrEP or PEP related barrier, please call that PEP or PrEP navigation line. If it's an HIV care or supportive care related barrier, please call the Positive Connections line. Actually, Carlos, if you don't mind navigating back a slide, I want to just put those up for folks again. If it has to do with accessing STD, sorry, forward, 2 more. There we go. Oh, the one that has the list of phone numbers. There we go, please, thank you. So we'll leave this up here for the Santa Clara County folks to make sure you've got all of these contact numbers for us. So the one that says STD care, that's how we can help schedule a patient, or a patient may call themselves to schedule for care there. That finding people number, that goes to our STD disease investigation team, but they can also help figure out if somebody needs testing or needs care for a bacterial STD, we can help you access by calling that number as well. Often you may be seeing your own patient but unable to provide affordable care to that patient's partners, and we can help you do that both by talking about systems for expedited partner treatment for bacterial STDs and by seeing the partners of your patients in our own care setting. So a lot of resources for you here at the county. In addition, we want every care setting to have their own resources so that you don't have to refer to us here. We will always be here as your safety net, but we want to build up your capacity as well. And so our provider detailing program, when we come to you with resources for offering PEP and PrEP and rapid ART eventually in your own setting, we will also offer guidance for how to get that paid for your clients. But we can work with you even if we haven't brought you that academic detailing, or if there are ways that we haven't addressed that in our academic detailing materials, we'd hope to incorporate that for you and help figure that out in your own care setting as well. Did I leave us time for one more? 5 more minutes.
We do have time for one more question because we do have some closing remarks. And the question I have is in relation to any sense of what the cost might be for the generic version?
I don't know. I'm gonna look to, I have a wonderful bird whispering in my ear via private chat. So if he wants to try to find any information on cost, because I can tell you when it was under patent, we were still seeing on the order of $1,500 a month for non-340B entities and $500 a month or $450 a month for Truvada for 340B. So I'm already, thank you. I'll call out my amazing academic detailer and health educator, Sundar Thapalia, who is sneaking me answers over text. So a comparable example in Australia is $8 a month. We are hoping to see something similar here, although I don't think we know just yet. So that would be, as you can imagine, a dramatic change in how accessible this medication is, from $1,500 to $8 a month. Now, even if we don't see that drop off, we have a lot of resources to help pay for it in various settings right now. But, and so send us your questions and send us your patients. But in the meantime, please look out for that information. Oh, and then I'm also seeing a kind message from our lead social worker from the Positive Connections team, offering his direct work phone number. So if somebody either needs help accessing HIV care themselves or supportive services, or has a client who needs help accessing care, please feel free to use the Positive Connections phone number on the screen in front of you, or the one that's been posted into the chat. So I think we'll stop there.
Thank you, Dr. Rudman. A big applause for Dr. Rudman. Perhaps you can use your applause icon as a way of thanking you for your time and effort and an amazing level of content and analysis. I also want to take a moment to thank all the people that worked on this whole series: the Santa Clara Health Department, the County Health Department, the Health Trust, the Pacific AIDS Education and Training Center, and all the people behind the scenes that you never see, but it's all a process. And for that, I'm thankful. And please take a moment to fill out the evaluation. We had commented that if you want to get a copy of the recording of this session, please make sure that you send your email to Lucas Collazo, or even later, you can send it through the Pacific Training Center, and we'll make sure you get a copy of the recording. And with that, I'm going to sign off. Dr. Rudman, it's been a pleasure working with you and the entire team that's involved with this GTZ initiative. Signing off, thank you so much.